cholesteatoma with erosion of facial nerve canal and fistulization of lateral semicircular canal. So we will come back to this. Now, if you see here, acquired cholesteatoma. So basically, what happens is that where cholesteatomas can be acquired, they can be congenital. Basic issue is that there is stratified squamous epithelium, which because of perforation of the tympanic membrane, it goes retracts inside the middle ear cavity. Skin has got this characteristics. The DNA-wise, the skin cells exfoliate, so they keep churning more keratin, and this keratin becomes a ball, and this ball actually has got some properties to cause erosion, and this happens over years and years. Please remember that. And on a this will not enhance or anything. So uh, because this is going to be a always a clinical chronic otitis media, rule out a cholesteatoma. So on CT, we are not very good. About 50% of cholesteatomas can be picked up. But the principle is that you must have a non-dependent opacity with bony destruction. Please remember, bony destruction can happen in acute conditions like acute mastoiditis or acute otitis media, etc. So you have to be careful, and the clinical scenario will also be helpful. Now, if you see here, this is the anatomy of pars flaccida. Our case was pars tensa. So this is the prosaic space, which is the space candidate. What was this? Candidate 4. So this was the candidate 4, isn't it? Candidate 4, you did this case, correct?
Yes, sir. Yes, sir.
Okay, so your concepts just because you were mixing up between Prozac space and you were pointing out anatomy, which I'll show you later on, which was not what it was. So please concentrate on this case. Now, this is the anatomy of the Prozac space. This is the head of the malleus and the body of the incus. So the cholesteatoma is sitting here, and this will be visible when an ENT surgeon does horoscopy. They will see it clinically, and then there will be erosion of this bone, which is scutum. On the other hand, look at this cholesteatoma, which is much larger, which has caused erosion of the tegmen tympani. And here there is lateral semicircular canal, which it has eroded in fistulization, which is an exam scenario. So please remember that uh, you will see middle ear opacification. You can see these are the features which are commonly seen and might not be seen in each and every case. Remember that scutum can be eroded, ossicular erosion can be there, ossicular displacement, so it can displace the ossicle as a mass. Expansion of editus ad antrum can happen. Lateral semicircular canal fistula. This is extremely important for the exam. These patients will be very symptomatic because they will be dizzy and etc. etc. Tegmen tympani erosion. This is important. Facial nerve dehiscence will be there. In our case, which I have shown you, there is facial nerve dehiscence and there is lateral semicircular canal fistula. This is a case of cholesteatoma where you can see this opacity, which is completely replacing the middle ear cavity, and it is causing erosion. Where are the ossicles? Because the ossicles are gone, that is erosion, and there is a opacity which is completely replacing it. This is the key thing which I want you to remember is the lateral semicircular canal. So this is the lateral semicircular canal on the normal side. This is the superior semicircular canal. Key point to remember is that there must be a bone between the lateral semicircular canal and the middle ear cavity. Here you can see that there is no bone. There is no bone. And this is known as fistulization, and this is classical exam scenario which you can see. This is what I call the Clint Eastwood sign. uh, from old classical movie Good, Bad, and Ugly. This is Clint Eastwood's gun. This is the barrel, and it is touching this white. So this barrel, and this is the superior semicircular canal. This is the this vestibule. This is the vestibule. So this should not touch the black. The barrel should not. You can see it here. So this is the Clint Eastwood sign, which is this is the barrel. It touches the white. This is the hammer, which is the superior semicircular canal, and here it is not touching the white. So this is fistulization of the lateral semicircular canal. Cholesteatomas can be very big. They can destroy everything. Please remember that they can destroy whole of the internal ear, and the patient might not have presented. So here you can see this cholesteatoma, which is causing a lot of bony erosion, and look at the fistulization of the lateral semicircular canal. Here is a big one where you can see that the internal ear is also completely destroyed. You don't see anything, cochlea, vestibule, etc. And actually, IAM is there, but it will take years and years for this thing to happen. So this is acute mastoiditis, acute otitis media and mastoiditis with destruction of the ossicles. You can see this air fluid level, and this is not a cholesteatoma. What I am trying to tell you here is that acute infections can also destroy ossicles and bone. But on the other hand, in cholesteatoma, it will be more chronic type of clinical, and there will be bony destruction. One cholesteatoma which I want to highlight is this one. So if you see, this is the medial side, this is the internal ear, this is the cochlea. Now you can see this is a non-dependent opacity, and how this is the epitympanum, and how it is causing erosion of the head of the malleus. So this should be etched in your memory. This is classical Prozac space. This is the outer side of the body. So let me go through this case. And this is a good one because there can be many, many things in the exam. I can go on and on and on about in this case. So now in this case, if we, so orientation wise, this is the IAM, sorry, internal auditory meatus. This is the cochlea. And now this is the lateral semicircular. Where my mouse is, you can see lateral semicircular canal. And here, even on this axial where I am pointing out, there is suspicion as if this bone here is missing. So you should develop this reflex of how to pick up lateral semicircular canal. Now, if you see the normal side here, you can actually always see a bone, white of the bone, uh, abutting the lateral semicircular canal. So here, portion of it is missing. So if I want to give you very, very good marks, you should have picked it up on an axial sequence. And of course, there is opacity. Where is this opacity? Please remember that the Prozac space is this one where I'm pointing out. So Prozac space is this space, which is outer space. This is the head of the malleus, and this is on the normal side, the incus. This space is Prozac space. Prozac space has got opacity, but the main opacity is sitting here on the medial side. So this is pars tensa cholesteatoma, and it is not in the Prozac space. And with that, on this, if I go superiorly, there is suspicion that there must be, this is the superior semicircular canal, there is suspicion that there might be some dehiscence here. So on this axial, but here, let's go to our good old facial nerve canal. You can see that this is the cochlea. I go superiorly. This is the labyrinthine portion. So let me go to the other side, which is the normal side. And you see, this is the labyrinthine portion, and this is how it should look like. Here, you can see that this thing is in communication with this opacity. So something is might be happening there. Now, where is the tympanic portion? Where is the tympanic portion? Let's go to the normal side, which is this one, and trace it. Now, this is the tympanic portion, and you can see how it goes below, where I'm pointing out below the lateral semicircular canal. Here, where is it? Let's go back. And you don't see it actually. You see opacity here. And then it appears, where I'm pointing out, it appears below the lateral and it goes and then the mastoid portion. So I go to a coronal, and on this coronal, see what is happening. Now, first of all, this is the external auditory canal, and this is the from this is the mesotympanum and this is the hypotympanum. Whole of the opacity actually is sitting in the epitympanum, but this is the classical Prozac space. It is not sitting there. The main epicenter is sitting here medially, and then is it causing tegment tympani dehiscence? So we go up and down, and maybe here it is very thin, so we can raise that issue. But here, where I'm pointing out, there is a definite dehiscence. There is a definite dehiscence. Let's go and trace the facial nerve. So this is the internal auditory canal, and here this is the owl, labyrinthine portion. It goes here, and now you are convinced. Where are the two eyes of the owl? They are gone, and they are abutting this opacity. The two owls are gone. So this cholesteatoma is causing dehiscence of the facial nerve canal. And please remember, very near to that was that erosion where I am pointing out. Now, if we trace it anteriorly, so this is the facial nerve, dehiscent canal, and then inferior to the lateral semicircular canal, it is normal where I am pointing out, and as we trace, it goes down. Coming back to the lateral semicircular canal, this is the lateral semicircular canal. And if you compare it with the other side, uh, just 1 second. As I've told you, Clint Eastwood sign, it must touch white of the bone, right? It is not touching white of the bone. This is here. It is touching this opacity. There is no white here. So there is fistulization. So this will be a pars tensa cholesteatoma with fistulization of the lateral semicircular canal and dehiscence of the facial nerve canal. Okay, thank you. Candidate 5, are you with us?
Yes, sir.
Let me give you the history of this patient. This patient is, oh, so what happened was that this patient is 71-year-old, right-sided mastoid surgery 6 years ago. And initially they have asked a CT scan, and they want us to rule out a recurrent cholesteatoma. Just concentrate on the right side.
Okay. I have requested remote control.
I've given you the mouse.
Okay, I am going through the images, and I can see that there is a soft tissue opacity, and it is okay. I can see that the soft tissue opacity is destroying the right mastoid ear cells. It is occupying the right external auditory canal. Um, I cannot appreciate a normal anatomy on this side since this is a post-surgical case. The ossicles. Uh, I can see the tympanic membrane. It appears normal. So this looks like a destructive lesion, which is. Can I see the soft tissue window of this patient?
And how will it help you?
I just want to see if
This is,
any.
yeah, what do you want to see in the soft tissue window?
I just want to see the external soft tissue involvement. How much is it? It is extending outside.
So, this is status post mastoidectomy. Mastoidectomies can be radical mastoidectomy, they can be partial. You won't gain anything out of it unless there is an infection, secondary infection. There is no infection.
Okay. So can I see the coronal view? Okay, this is the coronal view, and I can see that I can see the inner ear structures. They appear unremarkable. There is irregularity of the tegmen tympani.
Where is the irregularity? Show me.
So this part appears irregular.
That can be normal. Okay, what is your
I
control?
can So this can be a recurrent mass, and it is non-dependent. So this can be a recurrent cholesteatoma.
This is the surgical cavity, surgical field. A normal mastoidectomy looks like this always. How can you confirm that there is a recurrent cholesteatoma?
MR, we can do MR for this patient.
Okay. MR.
Okay, this is T2 cornel, and I can again see some mastoidectomy changes here. Sir, can I see the diffusion weighted imaging? Okay, this is the diffusion weighted images, and I can see that there is a diffusion restriction at the same side which I saw earlier on CT. And this confirms that this can be a recurrent cholesteatoma.
Okay, thank you. So this was a recurrent cholesteatoma. Basically, what happens is, in post-surgical cases, as I'm reading from the book, it is hard to differentiate recurrent from granulation tissue fluid and fibrosis on CT. So we do DWI. This is what we call non-EPI, non-echoplanar imaging DWI sequences. Because otherwise there will be a lot of artifacts. And please remember that cholesteatoma by definition is epidermoid. Epidermoid and cholesteatoma is the same thing. And if it is in the skull, we have made life difficult for ourselves. If it in the skull, we call it an epidermoid. In the temporal bone, we call it a cholesteatoma. If it is in the intracranial cavity, we again call it an epidermoid. And it can be congenital and it can be acquired. So here The key thing is that in post-op, in post-op cases, uh, the opacity on CT scan, it will always be opaque, just like in our case. And you are never going to, it's a surgical cavity. There is a concept of radical mastoidectomy where they might have removed everything. So you cannot differentiate because three things can be there. One is fluid, second thing is granulation tissue, and the third thing is cholesteatoma. Key point to remember is that the only thing which will show restricted diffusion is recurrent cholesteatoma. There was a concept that you do special type of imaging where you can uh, differentiate between the three. How do you do that imaging? This is on this slide. You do 45-minute delay scan with contrast. Granulation tissue will enhance, fluid will not enhance, cholesteatoma will not enhance, and cholesteatoma will show restricted diffusion. By this technique, if you do with contrast 45-minute delay, you can differentiate between fluid, granulation tissue, and cholesteatoma. Counter argument is that why are you doing, even if you say it is granulation tissue versus fluid, it will not change management. So just do DWI sequence and correlate with other non-enhanced sequences, correlate the anatomy of it, and tell the clinician what it is. So here you are. This is a post-surgical case. This is 45-minute delay. And on DWI, there is no enhancement. So there is no recurrence in this case. In this case, there is recurrence because of DWI. And this is a bilateral case, had previous bilateral surgeries. And on the right side, you can see high T2 and on delayed post-contrast enhancement. So this is granulation tissue. On DWI, there is nothing. On the left side, there is no enhancement. On DWI, there is what we call uh, restricted diffusion. So coming back to the description of this case, key thing is that you must develop your eyes on post-surgical. So this is all post-surgical appearance. Having said that, with this post-surgical, you can see this dehiscence where I am pointing out. There is a dehiscence and you can see that the intracranial cavity is there, and this dehiscence should raise the issue that something is happening. And on the coronal, here you are. This is the cavity, and this is the cavity, and this is what we call tegmen mastoideum, and you can see erosion here, superior to what. So you never know what is what in this as far as a CT is concerned, but there is erosion. And this particular finding is of, yeah, so if you see here, this is the lateral semicircular canal, and this is portion of the superior, this superior wall of the external auditory. It is completely gone because of surgery. And this is the epitympanum. And so everything else you cannot make out. But key thing is that on a DWI sequence, you can see that there is a bit of restricted diffusion here and here. And you can see how it looks like it will be, the resolution will not be very good, but it will give you the diagnosis, non-EPI, non-echoplanar image DWI. Okay, thank you very much. You got the diagnosis, but a bit of fine touch was there, lacking there. Otherwise, you got the
Thank you,
diagnosis.
sir.
Well done. Okay, now Next case is 6 year old. No, just one second. So this is a 52-year-old male, acute symptoms. Left, they are worried about the left side. They say acute otitis media. Over to you. Can you ask for the mouse? Who's the candidate? Is it
Yes, good evening, sir.
yes? Can you ask for the mouse? You know how to ask for the mouse?
Yes, sir, I know how to ask, but today the option is not showing up.
Okay, so let me scroll. So this was as a brain scan it was done. So on the brain, you comment on the temporal bone.
Okay, so this is bone window, CT temporal bones, in which there is an opacity seen in the middle ear cavity at the level of cochlea, as well as opacification and part destruction of mastoid ear cells. There is a dependent density seen in the surrounding the in the epitympanum, as well as mesotympanum, as well as surrounding the ossicles, which are part actually they are quite eroded, and it is the dependent because I can see air at its top, and there is part sclerosis of the surrounding bone, as well as somewhat erosion. Sir, I would like to see in the. I would also like to see the petrous apex, which is normally seen. So the epicenter is in the middle ear cavity, and in the mastoids with part dehiscence of the posteriormost part of the mastoid ear cells. Um, yeah, the focal loss of bone is there, sir. I would like to see the images on the coronal as well. These are sagittal images.
Sorry, this is slightly oblique. So I'm showing
Okay.
simulated coronal, right? This coronal oblique type of thing because the patient could not cooperate.
Okay, so there is a focal loss of bone at the level of mastoids with mm, the
So
same findings are re-demonstrated. So
okay,
if the patient has, yes, sir.
yeah, what is your conclusion?
So if the patient has presented acutely with fever and constitutional symptoms, it can be acute mastoiditis, but I would also like to see the soft tissue window to see adjacent cranial status of adjacent brain. Mm, in the brain, there is a focal. Sir, can you please show me the area where of internal acoustic meatus? Just and can you please change the window a bit? The soft tissue is appearing a bit hyperdense type. If you can just okay, yes, that's better. Um, there is hyperdensity seen in the adjacent region, but I'm not quite convinced about the.
What will you do?
Sir, I will do MRI, MRI contrast enhanced MRI,
Will be
because I've
can
suspicion that it is mastoiditis, acute mastoiditis with bony erosion. So I'm quite concerned about the adjacent venous sinuses. So
so
to rule out any,
I warn you, this is a in, in your exam. How do you deal with an A&E patient, by the way? Don't ask for an MR, right? In
sir, contrast enhanced CT.
and this is the if you start asking for MR, it might happen tomorrow, next day. So you should ask for initially contrast, and if the examiner wants, can show you the MR. Don't do this mistake because this is how radiology is practiced. Now, Having said that, uh, an MR was done next day actually.
Okay. These are the no, these are the contrast enhanced sequences of the MR in the same patient in which there is a hyperintensity is seen posterior to the mastoid cells.
Need contrast enhance.
Sir, sir, is this is contrast enhanced
Why do you say that?
because I can see vessels in the temporal, yes, in the scalp and in the temporal fossa. Yes, at this point.
If you see a stir sequence in the pelvis, it will show you any every vessel of the pelvis. Does it mean it's contrast enhanced?
Okay, sir, this is flare
And why do you say this is so?
because the brain parenchyma looks like a typical flare imaging. White matter is hyperintense. Gray matter is hyperintense.
Okay, so what have you picked up?
Sir, I've picked filling defect and fullness and hyperintensity in the region of sigmoid sinus, as well as a hyperintense area in the mastoid ear cells with adjacent significant soft tissue thickening and hyperintensity. So this is my conclusion is that this is a case of acute coalescent mastoiditis with adjacent sigmoid sinus thrombosis, and it needs to be urgently communicated to the referring physician for further management.
So, okay, so we stop there, madam. You took your clinical practice. If this is the case which I have, you once you see it on the
Sir, sir, your voice is somewhat muffled. Can you please say
you know,
again?
the point is that in your day-to-day practice, in your clinical practice, when you see, uh, can you hear me?
Yes, sir. Now I can.
Okay. So the point is that you have made this diagnosis on the flare.
Hmm. I
You
should be saying T1 post
How do
contrast.
just think in the exam, you are reporting it in your day-to-day. Do you report it on a flare that this is an abscess? Will you?
No.
So this is what in the exam also ask for a sequence yourself. Be proactive. You should not have concluded the case here. You should have said that I want to confirm it. And you can ask for a DWI if you want, is there this? You can ask for a post contrast, things like that. So that is the main feedback as far as otherwise you have picked up the findings. So in this particular case, uh, this was again automastoiditis with uh, cerebellar abscess. This time it was a cerebellar abscess. And the candidate did well, where picked up the findings, and there was a dehiscence here, did very well to see on soft tissue window that there is nothing visible. Actually, there was none. One point is that in E&E cases, it is critical that you deal as an E&E case because the MR will be delayed. So you can also be elaborative and say that, I will do a contrast enhance, and if MR is available, it will be a better modality to highlight that point. Now, on this flare, so first of all, it was a flare. In flare, the white matter is black, remember that. And in a T1, white matter is white. So this is a T1 where the white matter is white. Now, so on flare, we can see that there was something sitting here. Now, where is it sitting? So one can ask for other sequences to confirm it. And in this particular case, this was, here you are. There was an abscess there, and this was actually an extra. axial abscess. It was sitting just outside the cerebellum, touching the meninges. It was extra axial. Okay, thank you. Next, please. So the key point for you, candidate, is that the what you ask is critical. That you ask what you ask and how you deal it in day-to-day practice. Okay, now next candidate.
Thank you, sir.
Thank you. Next candidate.
Yes, sir.
Okay, your candidate number is
7.
7. Okay, so this is an A and E case. What happened is that this is 83-year-old fall in the room. So she fell at home, and they are worried about any intracranial hemorrhage. So because of time factor, this is the brain. We don't see anything much, right? So anything else? Do you see anything else, madam?
Yes, I'm presented with CT scan axial sections. Here I can see that there is soft tissue
Excuse me.
pacification seen.
Excuse me. Can you ask for the mouse?
Yes.
Yeah.
Okay.
Just go to the base of the skull, temporal bone, and see if you see.
Yes. There is a soft tissue opacification, soft tissue mass-like opacification seen in the region of the jugular foramen,
Hmm.
and also seen extending into the region of middle ear cavity.
Where is the
Uh,
medullary?
and the
Madam,
bony
where
plate.
is the middle ear cavity?
1 minute. Or I yeah, I can see it on the bone window, maybe. It's not in the middle ears. Sorry. The mastod ear cells are also seen opacified, and there is loss of the bony. There is loss of the bone with the at the region of the cerebellum, and there is opacification of the right mastoid ear cells. Now on these images, I want to see the this is the middle ear cavity in the region of the adytus and mastodantrum, and this epitympanum region. There is also a defect in the tegmen tympani over here. Mm, and there is a bony destruction in the region of jugular foramen. So it could be due to any mass lesion which is based on the in the region of the jugular foramen. I would like to proceed with the post contrast images if available.
Yeah, so actually, we have got an MR. Over to you.
All right. These are the axial sections of MRI brain.
Region.
T1 weighted images. Here I can see again the soft tissue mass, which is predominantly hyper to isointense on the T1 and giving some fluvoid appearances. These are characteristic of salt and pepper appearances, which are seen in for the glomus jugulare. I like to compare with any previous imaging if available, and with the clinical symptoms if the patient has any symptoms of paraganglioma or
So what kind of symptoms do you expect?
I will like to see first extension into the tympanic cavity, as there are sometimes extension of the jugular into the tympanic cavity. Um, Patient could have a tinnitus or
Okay, thank you.
okay, thank you, sir.
So this was a glomus jugulotympanicum. And so the glomus tumors in the middle ear cavity, the epicenter can be around the jugular foramen. When it is around the jugular foramen, we call it glomus jugulare. From the jugular foramen, if it goes into the middle ear cavity, then we call it glomus jugulotympanicum. And then there can be another one which can be just in the tympanic memory, tympanic cavity, as in the middle ear cavity, and we call it glomus tympanicum. Please remember that they are associated with various types of syndromes. So they can be familiar, they can be bilateral, and they can be what we call multiple. And interestingly, when they are in adrenals, we call them pheochromocytomas. So the point is that you can get long cases, etc., etc. So another in your book, there is another differential, which is jugular foramen lesions. Glomus jugulare is one of them. And so here, if you see this case, it tells you that there is a soft tissue tumor which is extending into the middle ear cavity, non-specific. When you give contrast, you can see everything is enhancing. So these are extremely enhancing tumors. These pictures tell you everything. So this is this is around the jugular foramen and it has gone into the middle ear cavity, glomus jugulotympanicum. This one is completely filling up the glomus, the middle ear cavity. So this is glomus tympanicum. This is one which is sitting here. And so another picture showing you the similar thing. Key point to remember. On a CT scan, develop your eyes to see for permeative bony destruction. They are slow growing tumors, they grow over years, but because of their vascularity, etc., they cause permeative bony destruction like this. You see this? Permeative bony destruction like this. And this is how you differentiate it with the neuroma. Let's say neuroma from any nerve. Another point which the candidate very well picked up, I had intentionally shown a T1 weighted pre-contrast sequence. These are extremely vascular tumors. And on a T1 weighted pre-contrast sequence, we have got salt and pepper sign, where there can be small hemorrhages or slow flow in the vessels, and high flow in the vessel is low signal. So this is salt and pepper sign. So these are two different cases. This is permeative bony destruction. It is a key sign which will differentiate it from a schwannoma. So, and salt and pepper sign. This is a schwannoma, and you can see that it is causing expansion of the jugular foramen. It is causing enhancement. So enhancement will not be very helpful. You remember the two signs on pre-contrast T1, salt and pepper, and permeative bony destruction. Look here, look at the outline. This is permeative bony destruction. This is a schwannoma on an MR, which is enhancing and it is going into, so, it can be from any cranial nerve of this region. This is a schwannoma. Wherever schwannomas are, they will cause bony expansion. This picture also tells you how the radiological features of a schwannoma will be. So, in differential diagnosis, meningioma, you have to consider in this region, when meningiomas are there, there is a concept of intraosseous extension. and there will be hyperostosis. This picture tells you, next time I'll show you a few cases of meningiomas which are going into the bone. And please remember in the exam, because of hyperostosis, they might show you a plain X-ray where there is hyperostosis, and temporal bone can cause, is a known site. So this is once again jugular foramen cases. Now we go to so the key thing here is that so first of all, classical exam scenario on a soft tissue window. Please remember today we are doing temporal bone, so your mind is knows that it will be something there. But this is a case, and it goes into the carotid space from here. Ask for the bone window, and now see that sign of the software actually is hanging, so just bear with me. Now it's fine. So if you see, look at the edges here, and this is the permeative bony destruction, and this is a key exam sign in this case. Look, mention that this is permeative bony destruction. Then the candidate did very well. I showed T1 without contrast, and here you can see this salt and pepper sign. There are high signal, and where there is low signal means these are vessels which have got high flow, very high velocity blood, which is low signal, and how it is going into the carotid space. So just to make a point that if you see the patient has moved a lot, but you can see how it enhances. Enhancement will not make a difference, but these two signs are critical. Okay, well done. Now, this patient, candidate, what is the number of candidate?
Assalamu alaikum, sir. Candidate number 8.
8. So here, if you see here, this what happened was that I'll show you this in a PowerPoint mode because just before the this session, I just realized that the appropriate MR has not been downloaded. So this patient is interesting because it is 62-year-old and initially presented with acute mastocytitis type of findings, and this was the original CT scan, and we can see that there is opacification, etc., and we can see that there is otitis media, and maybe there is a bit of erosion here. Nothing new. I've already shown you quite a few cases like this. The patient initially became better on antibiotics, etc., and but after 2 weeks presented again with symptoms, and this time patient had developed sixth nerve palsy. So I will show you in a PowerPoint mode, and so your Viva case will be in PowerPoint. So 2 weeks later, the patient presented with diminished vision, left eye with left sixth nerve palsy, which is the lateral rectus, right? So this is a attenuated sequence. There is nothing much here. So this is a fat saturated flare sequence.
Okay, sir.
The petrous apex, anything happening there in the apex?
Sir, do I have to tell you on this or do I have to ask you for the remote?
No. This is a PowerPoint. So it's
Okay. Okay.
you
Okay,
just
sir. Yes, sir. I can see that there is extension of the process, the infective etiology, I suppose. up to the petrous apex, and if the sixth nerve is involving, and the patient is having palsy of the sixth nerve, lateral rectus muscle, it should involve the cavernous sinus as well. And in the first image, I can see that the process is extending upwards towards the cavernous sinus as well. So this is the extension of the process into the base of the brain or to the cavernous sinus region. So in the first row is the plain coronal sections, and the second row is the post contrast. And here I can see that there is contrast enhancement noted at the level of the lateral wall of the cavernous sinus, I guess, which is also somewhat abutting the carotid ICA, internal carotid artery. So this is basically extensive petrous petrous epicitis, which is leading to palsy of the sixth nerve. So this is an emergency, and will refer the patient to the ENT and eye department for further management. The other name for this infection is Gordenigo syndrome. Sir, and I can see that there is also enhancement of the muscle.
Okay, thank you. Well done.
Thank you, sir.
Now, this is Petrus epicitis, where there is suppurative infection of pneumotized portion of apex due to extension of mastoiditis. So now the candidate did very well. This was the initial CT scan in which we can see that, the signs which I already showed you. Now here, what is happening on this flare sequence, we can see this high signal at the petrous apex. On a post-contrast, this row is pre-contrast T1 fat saturated, and this is post-contrast. This is the cavernous sinus. This is the cavernous sinus. Actually, you can see that there is a bit of soft tissue because there is no soft tissue on the other side. And this soft tissue is enhancing. So the infection is extending into the cavernous sinus. And if you see, this is T1 weighted axial post-contrast, and you can see that enhancement at the petrous apex. Look carefully here. This is the internal carotid artery. This is the internal carotid artery on the other side. You can see this enhancement, and the cavernous sinus is sitting there on an axial. So I will expect you to pick it up even on an axial if you don't see, if I don't show you a coronal. This is irrelevant because the patient also had a PET scan where it was showing up. Anatomy, because the questions will be about anatomy. Now the sixth nerve passes through a canal which is in the sphenoid bone. Please remember, it is not in the temporal bone. This is known as Dorello canal. It passes through it and then goes into the cavernous sinus. But there are other nerves which are passing into the cavernous sinus. So in the cavernous sinus, there is oculomotor nerve, third nerve, trochlear nerve, which is fourth nerve, and then the sixth nerve. The symptoms are because they supply the rectus muscles. Of course, there will be the trigeminal the first branch and the second branch of the trigeminal. They also, ophthalmic and maxillary, they also pass through the cavernous sinus. So these questions can be asked in your exam. This picture tells you what happens, that this is that Dorello canal, and there can be infection. So the petrous apex is sitting here, and so both the bones are next to each other, and that is why it will. So this will be a question in the exam, that which foramen does it pass, and it doesn't pass through the petrous temporal bone. So remember that. So this is the clivus. And you can see that this is the petrous apex where I am pointing out. So this is the apex. and the nerve is passing here through this is the cavernous portion. So this is passing through the sphenoid brain. Well done, candidate 7.
Thank you, sir.
Okay, this is second last case of the day. This is candidate
9, sir.
9. Okay, that was candidate 8. So this is second last case of the day. This is male 69-year-old, uh, had twice strokes in the past, and uh, they're worried about any new acute finding, particularly hemorrhage. So I will go through it and then I will give you the mouse. I've already approved your mouse, but I'm scrolling it. So this is old infarction, and there was an old infarction here. You go to the base of the skull. I will show you the bone window. Over to you.
Okay. So I'm provided with the CT scan images, bone window. I first roll the entire stack.
Uh, So just look at the right side, please. Right side.
Okay, sir. Okay, sir. So on the right side, I could appreciate that there is uh, some destruction noted in the petrous apex with uh, suggestion of some soft tissue density, which could I will later confirm on the soft tissue window involving the petrous apex.
Okay, leave the mouse.
Yes, sir.
This is your soft tissue window.
Okay, sir.
And so,
Yes, sir. So there's a soft tissue opacity that is centered over the petrous apex, and uh, the jugular foramen seems fine to me. I would like to see the carotid canal.
okay, what else would you like to do now? Invest.
Sir, I would like a post-contrast sequence or
You did an MR. You
an
know,
MRI available.
yeah.
Yes, sir.
Please remember, I want to emphasize to everybody, when there is an A and E scenario, then an urgent scenario, as in abscess, etc., ask for a CT. Think what happens in the clinical practice. This is something which is very chronic happening. You can ask for a MR also. So this
Okay,
is
sir.
MR. This
Sir,
MR.
on the MR, yes, sir. I'm provided with the T1 sequences over genes of infarct are redemonstrated. I could appreciate a T1 bright lesion centered in the petrous apex, uh,
This one
concerning for,
is it?
sorry, sir, I think,
So it's a flare sequence. Please.
okay,
Okay.
okay.
So what is happening?
So there's a flare bright lesion in the petrous apex. So I would like to see it on the T1.
T1.
Yeah, so it seems bright on T1.
You can
So
move it.
I think,
You can scroll it.
so it's ISO too high on T1. Can I have a DWR?
It was irrelevant. There was nothing.
Sir,
Why
sir,
did you
post.
DWI?
Sir, I'm thinking of some cholesteatoma in the petrous apex, or so that's why you.
What else would you like to?
Sir, no, I'm thinking as the DWR is irrelevant. I would like to see a post contrast.
Okay. Don't move your mouse. Don't move your
Okay,
mouse.
sir.
I will
Okay, sir. Okay,
see you when I am
sir.
ready. So this is post
Okay, sir.
control.
Okay, sir. Sir, The lesion was intrinsically bright on T1 and is showing, I think it is showing slight post-contrast enhancement as well.
Excuse me, now
So,
you can move your mouse. See the lesion. Move your
okay,
mouse.
yeah, so I'm thinking of, as it's bright on T1, I'm thinking of a cholesterol granuloma in the petrous apex.
Good. Thank you. So this was a cholesterol granuloma of the P-TRAPS apex. Well done. So cholesterol granuloma, what happens is that cholesterol granulomas can be in the middle ear and they can be in the petrous apex. And they take years to develop. You know, there is a study in which they proved that that particular one they had images, it developed in 22 years actually. So the point is that there is a bit of the main pathology to remember is that there is granulation tissue inside, there is a bit of hemorrhage, and there can be cholesterol inside. The key finding, it will be expansion of the bone, number one, either in the middle ear or in the petrous apex. And and number one. Number two is that the key find on a T2 weighted sequence, they can have slightly low signal in the periphery depending on the how many blood products are there. But you are going to make this diagnosis on a T1 pre-contrast. On a T1 pre-contrast, it will be high signal. So this is what the candidate was looking for. So that was well done. And so petrous apex lesion, there is another differential diagnosis. And most common petrous apex lesion, it is T1 and T2 high signal. So this, remember this. This is another example where there is expansion of the bone, real, much more than our case. And on a T1, this is a T1, this is high signal. On a T2, you can see a rim of low signal here, which can happen because of the granulation tissue. On post contrast, it might not be very helpful because it is inherently high signal on T1. Cholesterol granuloma, this is from the book, that this is how it will look like in middle ear, and this is how it will look like on uh, in petrous apex. Another one where there is expansion here, and this is high signal on T1 here. So that was very well picked up and well done. And now let me go through the case quickly. So this was the expansion. So if you compare it from this side, so this exactly where I'm pointing out is the petrous apex, and you can see that there is expansion here. And then we go to the MR. Key thing is not the post contrast, but the pre contrast. Now here, this is a post contrast T1, and you feel as if there is a nodular enhancement here. But if you go to the pre-contrast T1, which I believe was, where was it? This is it. It is inherently high signal, inherently high signal. So the high signal on pre-contrast is on which the diagnosis is confirmed. This is actually, uh, now I'm showing you, this is post-contrast, right? Thin slices. And equivalent T1 is this one actually. And you can see that on pre-contrast, it was high signal. This focus was high signal. So key point to remember is this word and plus the T1 is the key. Well done, candidate 9. Last case of the day. Candidate 10, are you with us?
Yes, sir.
Last case. Now, in this case, what happened is that this is a 53-year-old female, unexplained hearing loss and left-sided tinnitus. Unexplained hearing loss. So that's the symptom, right? Remember that. Now,
Okay.
on imaging, we find is that if you see the thyroid ear cells, they are all opacified, and then there is a opacity here in the middle ear cavity. Now, uh, if you see here, this is the external auditory canal, and you can see that this opacity is filling up the middle ear. This is the malleus, this is the venom, and this is the body of the incus. Uh, there is no definite any bony destruction or anything. Now, with this kind of clinical, what comes to your mind, madam? Over to you. And what will you do next?
Um, there is no bony destruction, and there is soft tissue filling the middle ear and the mastoid. So I'm suspecting that this is my going with infection rather than malignancy.
So there is no bony destruction. So the symptoms were that the patient has got no signs of infection or anything. The only thing is that she has got unexplained hearing loss and tinnitus.
Okay, so I would like to check the nerves, the vestibulocochlear nerves,
What will
and
you,
sorry,
which investigation do you want?
MRI to check the nerves.
Okay, so I have given you a T2 weighted sequence. Over to you. Scroll it, please.
Okay, this is MRI. Okay, this is MRI T2, and I can see that there is effusion noted in the mastoid air cells. I would like to check the vestibulocochlear nerves. So,
So the nerves were fine on the CIS sequence. There was nothing abnormal there.
okay,
Look at the middle ear.
middle ear. Okay.
Point it out to me, please.
Doctor, sorry, I have problem in the scrolling. There is lagging.
Okay, just leave it. Leave it. I'll scroll for you. So
Okay, thank you.
so this is the mastoid ear.
Mastoid, yes.
Now this is
The
what part?
vestib. This is
Now
the
you don't move your
vestibule.
mouth. Don't move. I will ask you.
Okay,
So what is this structure?
this is the cochlea.
Okay, and what is this structure?
This is the semicircular canal.
Okay, and which part is this opacity filling up?
Uh, this is filling the middle ear cavity.
The middle ear cavity. Now, how do you explain this opacity? What is the signal, and what is the signal of the
This
ma-
is hypodense signal in the middle ear cavity. So this is soft tissue. Uh, because the signal in the mastoid, the effusion appear high in T2.
So what would you like to do next?
Post contrast.
Okay, so post contrast.
Yes. Yes, the soft tissue lesion that was high low signal in T2 is seen rapidly enhancing now in post contrast. Uh, Yes.
So, madam, what is your conclusion?
So I'm suspecting that this is enhancing soft tissue lesions within the middle ear cavity. Uh, uh, this may be something related to the schwannoma in the nerves
But
or
which nerve will be within the middle ear cavity?
within the middle ears. So this is the facial nerve.
You know, the facial nerve schwannoma will be in the facial nerve canal. Usually they are not as large. This thing is filling up whole of the cavity.
Mm. So this is but the cochlear nerve will not also be in the middle ear cavity. So yeah, so this is the tympani nerve. Uh,
Madam, the schwannomas do not behave like this, right? Schwannomas are very well defined. By the way, there is a concept of facial nerve schwannoma, which can be in the canal. They are very small and things like that. This thing, this mass is completely filling up the middle ear cavity and it
mm,
is enhancing profusely. So, what comes to your mind?
Mid-P meningioma,
Meningioma. Okay.
middle ear meningioma. Yeah.
Okay. So, uh, sorry, what, where am I? This was a meningioma of the middle ear. Middle ear meningiomas are extremely rare but can happen. Usually, meningiomas will occur next to the temporal bone and go into the middle ear. This is a rare tumor which can arise. There are about, I think, 150 reported. I'm sure there must be thousands out there, but 150 have been reported, just confined to the middle ear. Please remember that if you go back to your embryology, surrounding the head and neck, even in the neck, in the upper neck, carotid sheet, etc., you can get meningioma. So that concept should be there. So mostly meningiomas in the middle ear, in the what we call in the temporal bone will be extra osseous. You will see them in the base of skull, sorry, in the posterior fossa, and from there they will go in. But this was unique. But one thing which I want you to please remember that in differential, in the tumors of the middle ear cavity, one thing which you could have considered is this thing, glomus tumor. Please remember that there is a tumor which is known as glomus tympanicum, glomus jugulare, which is just at the jugular foramen, glomus jugulotympanicum, which goes from the jugular foramen into the middle ear cavity. When it arises just in the middle ear cavity, we call it glomus tympanicum. And this is also glomus tympanicum, which was sitting on the promontory. So that can be considered in the differential. In this particular case, so what happens is that when you see uh, clinically, when they see these patients with a glomus tympanicum, they they will see what they call a very vascular or red tympanic membrane, which was not seen in this case. So this is a good case again to learn anatomy. The candidate did well because if you see, it is filling up whole of the middle ear, filling up whole of the middle ear, hypo, meso, and epitympana. And please remember that schwannomas, by the way, that is beyond 2B level. So they are not going to show you facial nerve schwannomas. can happen, and they are very small and they can enhance, etc. They will be sitting in the mass in the so anatomy is checked there. It cannot be a schwannoma. It is something which is filling up. Now, if you see the T2 weighted sequence, which told you that it is slightly different in characteristics as compared to rest. And again, it beautifully shows you the anatomy on an MR. It is completely filling up the middle ear. And anatomy doesn't change, the modality changes. So cochlea and vestibule, etc., lateral semicircular canal, it is filling it up. And on a T1 pre-contrast, this is pre-contrast T1, and this is how it looks like. But on post-contrast, so there was no restricted diffusion, by the way, in this case. And then on post-contrast, it enhances uh, completely. It enhances completely. And if you look carefully, there is enhance where I'm pointing out, see how enhancement is going right and left. And so look where it is going superiorly. So a bit of meninges are involved. So the point is that this is a middle cranial nerve, middle ear meningioma. And the key thing was that to understand the anatomy of it. Now, if you look carefully, now you will convince yourself. Do you see that this is brain parenchyma? And you can see that the meninges are involved. So you could have asked for a coronal sequence to confirm that diagnosis and how it is going down here also. Sort of a tail sign type of a thing. Okay, madam?
Okay, doctor, thank you.
Okay, then thank you. So today I selected cases in which particularly the last case also, which was to highlight the role of anatomy. And anatomy was the key. And I have actually shown you all cases from one differential of Chapman. And some of these are slightly beyond FRCR, which I highlighted, but this is only one differential in your Chapman, middle ear. So that was the key. And another thing, which is that you should repeat and repeat and repeat again and again. Anatomy is the key. Anatomy is the key. And this is what they are going to ask. Today, I did not have time to sort of grill every candidate on anatomy, but in the exam, this is what they are going to do. So please remember, what is this? What is this? What is this? So that is the key. Next session, we will continue with base of skull, orbit, and paranasal sinuses. The idea is that in the same go, cover this region. So next session will be similar to today. The anatomy will not be as extensive as of today. This was too much. But having said that, again, you have to revise base of skull. Any questions? So
Thank you, sir.
there was no hyperostosis as far as this case is concerned. Hyperostosis happens when the meningeal cells, they go into the bone. This was per se a meningioma which was arising from the middle cranial cavity. And you have to go back to embryology because the meningeal cells are there. They are in the surrounding structures and things like that. So hyperostosis is, of course, more common, and this one was sort of a rare finding. Pars tensa and pars flaccida cholesteatoma. So I'll go back to anatomy to show you the difference. Uh, pars tensa cholesteatoma and pars flaccida cholesteatoma is the question. So what happens is, uh, consider yourself being a, the tympanic membrane actually has got part. It is a clinical name. The ENT use it, pars tensa and pars flaccida. And pars flaccida is sitting here for us radiology wise. It is pars flaccida cholesteatoma will be in the Prozac space, which will be in between lateral to the body of the malleus and the head of the correction, the body of the incus and head of the malleus and next to the scutum. That is why it will cause erosion of the scutum. And on an axial, this is the territory of pars flaccida. So if you see here, this is external auditory canal. And if you go to epitympanum, so this portion is the what we call the Prozac space, where the pars flaccida. On the other hand, pars tensa. Now, I did not go into great details of this anatomy, but I just covered it superficially, that this is the posterior. Now, if you see, let me orient you that this is the lateral semicircular canal. This is the epitympanum. I am going into the mesotympanum. I am going to the mesotympanum. Now, here in the mesotympanum, if I stop here, there is this structure here. This is the facial nerve canal where I'm pointing out. This is the facial nerve which is going down. It is going out, right? I come back. Here, there is a strict structure which is pyramid. We call it the pyramidal eminence. This air here is known as sinus tympani, and the air here is known as facial nerve recess. Pars tensa cholesteatoma will sit here actually. It will sit posteriorly. So, and from here, of course, it can go up and down. It all depends on the size. So this is the difference between the two. I hope it is clear now. Is there any other differential of fistulization of lateral semicircular canal? For your exam, they will only show you this cholesteatoma, right? And uh, as far as difference between acquired and congenital is just age. These patients which you will see is always acquired. Uh, and Granulation tissue enhancement is never so profuse. Please remember that. Granulation tissue enhancement, the vascularity is very poor. And that is why if we want to do with contrast MR, we do it 45 minutes delay. 45 minutes delay. Why do we do 45 minutes delay? Because the blood supply is so poor. On the other hand, a meningioma, which I showed you, that will enhance very, very profusely. What were the names of the two recesses? So one recess is sinus tympani. Sinus, this one. This is pyramidal eminence, sinus tympani, and this one is facial nerve recess. This is the pyramidal eminence. So these are the structure on the posterior wall of the middle cranial, sorry, of the middle ear. So, I think you want to say that how did we conclude that this was a meningioma? Key thing was that it was not glomus tympanicum. Why was it not glomus tympanicum? One thing was the clinical. Please remember, glomus tympanicum uh, uh, in clinical, it will be what we call a red tympanic membrane. It will be very, sorry, when tympanic membrane is a very thin structure. When they do oroscopy, they will see a red tympanic membrane, number one. In this particular case, it was scarred. But the key thing as far as radiology is concerned, you remember the signal. It was on pre-contrast. It was not high signal. It was intermediate signal, and then it enhanced like anything. The key thing was the coronal post-contrast, contrast enhanced, where adjacent meninges, the enhancement was extending into the adjacent meninges. So it was a meningioma, and it was not a glomus tympanicum. Can the case of the